Hello, my name is Cleida Tani. I'm a doctor of physical therapy, and in this course we're going to talk about scoliosis and how to treat scoliosis with physiotherapy techniques. The first lecture we're going to start now, we're going to explain what scoliosis is, what is the deformation, the deformity, and the basic classification of the scoliosis. So, scoliosis is a three-dimensional deformity, which means that you have a deformation of the spine in the frontal, sagittal, and transversal plane. And normally we're saying that a person has scoliosis if they have more than 11 degrees of Cobb angle that we're going to explain. So in the frontal plane, which you can see from the back side of the patient especially, you will see we have convexity and concavity. And in the sagittal or lateral curvature, as we say, in the sagittal plane, most of the time we have flattening of the thoracic spine or of the thoracic kyphosis and lumbar lordosis most of the time, but sometimes when we have more than 35 degrees of the Cobb angle, then we have hyperkyphosis of the patient. And in the horizontal plane or the transversal plane, which is the basic deformity, especially for the scoliosis, and this is the most important part that we have to treat especially, is the rotation of the vertebra. So in the frontal plane we have concavity and convexity. In the sagittal plane most of the times we have flattening of the spine, and in the horizontal plane we have rotation of the vertebra. Sometimes the rotation of the vertebra is so big that in some people we have torsion of the vertebra, which means that the vertebra itself it's in deformation. So you don't have a normal vertebra, but we have a deformation of the vertebra itself, on the structure of the vertebra. What happens in the ribs? It's when we have the concavity and the convexity. So this is the concavity and this is the convexity. In the concave part, the concave side, the ribs are compressed and close to each other, and they are rotated anteriorly. So it means that the ribs in the frontal, in the anterior part of our body are opened, okay? So in the posterior part they are compressed and they are pushed anteriorly. So anteriorly you will see a patient, his or her chest being more rotated anteriorly, and the ribs are open anteriorly in the concave side. In the convex side, the ribs in the back part are opened and they are pushed posteriorly. And here we can see the gibbus, as we said. And when we have the gibbus, in the anterior part, the ribs are compressed and they are pushed posteriorly. So the whole rib cage is completely derotated. In the concave side is rotated anteriorly, and in the convex side is rotated posteriorly. So the torsion of the vertebra and the rotation of the vertebra is very important also in the rotation of the ribs. And with this rotation of the ribs, you have to work a lot to derotate the ribs and elongate the spine. This is what happens in the vertebra. So you see that this is the concave side. So they are, the concave side, this is the posterior part and this is the anterior part. The ribs are pushed anteriorly, and in the convex side the ribs are pushed posteriorly. So this is what I explained, that we have the rotation of the rib cage, which is very important for our examination and for our treatment. What happens to the scapulas is that in the convex side, as you can see, the scapula is mostly elevated and sometimes it's in protractions, and in the concave side the scapula is in depression and it just stays on the ribs. Also the iliacal crest or the crista iliaca that you can see from the pelvis, in the concave side we have elevation of the pelvis, and in the convex side we have the pelvis is in depression, and I will explain it when we're going to examine our patient, okay? So if we take our vertebra, I will explain it again. here we have, this is the convex side, this is the concave side, okay? And here we have, this is the convex side and the concave side. So, this is the frontal plane, convex, concave, concave, convex, okay? In the sagittal plane, which is this part, we have or hyperkyphosis and hyperlordosis or flattening of the ribs. But the most important part is the horizontal plane, which means the vertebrae are rotated. And you will see that the processus spinosus of the vertebrae are rotated towards the concave side. So you see all the processus spinosus rotating the concave side, and the body of the vertebra, it's rotated in the convex side, okay? So this means that the ribs here will be open and pushed posteriorly, and in the concave side, the ribs will be closed and pushed anteriorly. Also for the cresta, as you could see, in the concave side, the iliacal crest of the concave side is in elevation, and the iliacal crest of the convex side is in depression. But not only this happens, but what happens is in the concave side, the iliacal crest, the pelvis, not only is in elevation, but it's also rotated anteriorly. And in the convex side, the pelvis is rotated posteriorly. So you also have a derotation of the pelvis, which sometimes, when you will, we will explain in the examination, you could see that this rotation can even be a torsion of the pelvis, which means the body of the pelvis is completely derotated in the same way as the vertebrae can be derotated, okay? So this is what you could see in a patient in the structural side of the scoliosis. Now, we are going to talk about the classification of the scoliosis. In the classification, we have the non-structural scoliosis and the structural scoliosis. Not structural scoliosis mostly is postural scoliosis, which means that we don't have a real structural deformation of the spine, but the patient just stays in his posture is mostly scoliotic, or it's against the pain. Sometimes people that have disc herniation, they can have a scoliotic posture because they are like moving against the pain or away from the pain. Or sometimes patients that have an abdominal pain, they can just rotate themselves and have a scoliotic position. The structural scoliosis is the most common, of course. We have the idiopathic scoliosis, which is like 75 or 90% of the children have idiopathic scoliosis. Then we have congenital and maybe neuromuscular or traumatic scoliosis. But when we say structural, it means that the spine is really deformed. We have deformation of the spine, we have derotation of the spine, and everything as we explained above. We classify the scoliosis according to the age. So you have an infant scoliosis, is mostly up to 3 years old. You can see the derotation. These are mostly the congenital scoliosis, which means that the patients, when they are born, they already have a deformity in the spine. Then we have the juvenile scoliosis, which is from the 3 years to 10 years old, and the adolescent scoliosis, which is over 10 years old. Depending on the age, the deformity, it's easier to treat or not easy to treat. If the patient comes like in his 14th or 50 years old, and they just saw that they have scoliosis, it's easier for us to treat them than a patient that is 5 years or 6 years old, because we know with the child, when they are growing, the spine is also elongated, and the deformity can be even bigger while the child is getting taller and taller. So the age is an indicator of how much the scoliosis will be derotated and how the treatment is going, if the treatment is going to be easy or not. Also, we classify the scoliosis depending on the size of the Cobb angle that we are going to explain after this, which is 10 to 20 degrees, which is, we normally like we say, that is a mild scoliosis, not an easy scoliosis, 20 to 40, 40 to 60, and above 60 degrees. The Cobb angle is formed, you can see it also in here, it's formed between the two parallels that are in the beginning of the vertebra that starts the scoliosis, and the vertebra the scoliosis ends. Okay, so these two parallels can create the Cobb angle. The apical vertebra is the vertebra that is more horizontal in the concave side. So where is the more horizontal vertebra? It's the apical vertebra. And the apical vertebra is the vertebra that is mostly rotated. So when we are going to explain the examination, you would see that we can measure the rotation of the vertebra with the Raimondi angle. Then we have the classification, topographic classification of the scoliosis, depending where the Cobb angle is, where the biggest angle is. If we have a cervical scoliosis, this means that the apical vertebra is in the cervical region, and the biggest Cobb angle is in the cervical region. This is very uncommon. Most of the time the cervical scoliosis comes mostly from a traumatic incident, or maybe a congenital incident like torticollis, where we have a contraction of the sternocleidomastoideus muscle. Then we have the cervicothoracic spine, which means between C7 and thoracic 1. This is also mostly congenital reason. The most common topographic classification of scoliosis is the thoracic spine, which is between T2 and T11, and the apical vertebra most of the times is like in T6 or T7. Then we have the thoracolumbar region classification and the lumbar topographic classification of the scoliosis. So the classification is done according to the main curvature, where the Cobb angle is bigger. Now we're going to talk a little bit about the idiopathic scoliosis. The idiopathic scoliosis is the etiology is unknown. So we don't know why the scoliosis happens. There are a lot of questioning. Maybe it's genetics, it's the structure, but anyways, we don't have etiology, or the reason is unknown. The negative effects of the idiopathic scoliosis are mostly the progressive development. So as we said in the beginning, depending on the age, the progression is bigger if the beginning of the scoliosis is in a smaller age. So if a patient is 5 years old, the progression of the scoliosis will be bigger than if the scoliosis began at 11 or 12 years old. The progression will be smaller. Then we have, mostly it's a cosmetic problem, but we have complications only if the scoliosis is more than 40 degrees, which can be like cardiopulmonary problems, or pain or muscular pain, especially when the patients are in their adult age. And also it's a social and psychological problem most of the times for the children. So the risk factors of the scoliosis are 6 risk factors. We are going to explain each of them. The age. The earlier the scoliosis starts, the more complications we have, and the treatment it's not as easy than the older age. The gender. Most of the times women are mostly more affected than men. This is statistics, but it's not determination that women have scoliosis and men don't have. But mostly it's the idea that women have more hypermobility. Their flexibility is bigger than men. Then the curvature localization. The thoracic spine, it's a more rigid spine. So if we have a thoracic scoliosis, it's not as easy to treat than a lumbar scoliosis, because in the thoracic scoliosis we have the ribs, and the ribs are rigid. So it's very difficult to rotate the ribs. In the lumbar scoliosis, we have the muscles, so it's easier for us to work with stretching and activating the muscles than in the thoracic region. So depending on the localization of the Cobb angle and the scoliosis, it's easier or more difficult to work. The elasticity, it's also, most of the times the patients that have scoliosis are really elastic. So the more flexibility a patient has, it's more difficult to treat them. We need to strengthen the muscles, and because the flexibility and the hypermobility that the patient have maybe caused the scoliosis. So our objective, or the idea for our treatment is that we want to strengthen the muscles and to want to elongate the spine especially. And also we have the curvature compensation, which means we most of the time see the line between the occipitum and the middle straight, so the line between the occipitum and the middle stance of the patient should be in one line. If we have a decompensation, which means the head is tilted in one way and the pelvis in the other way, this means that the greater the decompensation, the more severe the scoliosis is. Okay, so you have to see where the head, the pelvis, and the foot of the patients, if they are in one line or they are not in one line. Also genetics, but most of the times you could see that if a parent has scoliosis, maybe their child will have also scoliosis, so sometimes it's also genetical, but it's not really proven. Then we have the congenital scoliosis. The congenital scoliosis means that the patient is born with spinal deformity. This is seen when the patient is already born, or 1 year old or 2 years old, and you could see that some of the time we have a block of vertebrae, so some vertebrae from birth they are not divided, or we have a hemivertebra, so a vertebra is not fully developed. So this can cause scoliosis in an early age. And we have neuromuscular scoliosis. This you could see here that there are big scoliosis. This is mostly these scoliosis are mostly seen when we have a central nervous system diagnosis, like peripheral paresis, myopathy, central paresis, and the therapy depends on the development of the scoliosis, on the age of the patient, on their cognitive apprehension, and if they understand or not the treatment. And this was the beginning, the first lecture, what scoliosis is, and now the second lecture, we're going to explain about the examination and the therapy.